ऑनलाइन है। Ritika, you can sit. Okay. Okay, friends. Now we finished with the complete chapter on respiratory diseases and on gastrointestinal diseases. Now we start a new chapter that is on contact diseases, and the first class which we'll be having today is on trachoma. So, so what is trachoma? Trachoma is a chronic infection of the conjunctiva and cornea caused by Chlamydia trachomatis. Well, there are others which often contribute to this particular disease, but we'll talk about that later. You're well aware that trachoma is a disease, you've studied it in microbiology and pathology, you've already studied these things. So a lot of this will be a repetition, but we'll just run through it. It will be this. We'll today be having, because trachoma was a major disease in our country earlier. We have had some excellent programs which have been run for trachoma, and today we have, we can say that we have eliminated trachoma. So it is not a major public health problem today in our country, fortunately. However, it is a problem to be considered, and we should look at trachoma as a worldwide problem. There's, of course, there is. If you look at trachoma, there can be spontaneous resolution, or it can lead to various problems like conjunctival scarring or trichiasis, entropion. Trichiasis meaning inward deviation of the eyelids. Entropion meaning the lid margins being involved. Or there can be abrasions of the cornea by the eyelashes due to, and then resultant corneal ulceration, scarring, and visual loss. Earlier, we used to have a large number of cases of trachoma leading to blindness. Fortunately, today in our country, we have much less number of cases. Not that it has gone, but we have much less number of cases of trachoma and much less number of cases of trachoma leading to blindness. So the blinding is could be due to trichiasis, entropion, corneal ulcer, and sometimes this corneal ulcers can result in an emergency, which will have to be handled. The non-blinding infections may be due to superadded infections and may result in visual loss. What's mode of infection? The infection is purely from person to person, rather from eye to eye, from one person's eye to another person's eye. Direct or indirect contact with ocular discharges. So whenever you have trachoma and which you have some other superadded infections also, you will land up with the situation where you may have some secretions. These secretions are either transmitted by the fingers to another person, and or through various other things like use of common towels, or for that matter kajal, surma. These all things are, kajal, surma is very commonly shared by people, so you have, it used to be transmitted very often earlier through these means. Also, we have our common housefly, musca domesticus, and various other species of musca that we have. They help in transmission of the, or we have another species of flies, the Epiletus. These are the ones which transmit the disease. Sporadic cases can also occur from the genital region through venereal transmission, which is the genital localization of chlamydia, which results in transmission by the sexual route. Trachoma is can occur in families, that because if the contact is, there's a close contact in the family, there's sharing of towels in the families, fingers, transmission of disease through the fingers. So in whenever you're treating trachoma, you must try and treat the whole family. That's what we mean. It's a familial disease. The incubation period is 5 to 12 days. You're aware of this. You have seen this in your when you were doing your microbiology. Basically, the infection, the elementary bodies which penetrate the host, the cell phagocytosis, phagocytes it, then there is the differentiation which takes place, various differentiation, binary fission, and ultimately you have again number of elementary bodies being formed, and the cell explodes, releases the thing, and the further infection takes place. A vicious cycle of chlamydia which takes place. So, as far as trachoma is concerned, is a major preventable disease in developing countries. 1.9 million people are suffering from it and need treatment. WHO statement, recent statement also quotes this figure of 1.9 million suffering from the disease and need treatment. 1.2 million of these suffer from irreversible blindness. So it's a huge number of people who are suffering from this. And there are, if you start to look at how many people are at risk, there's 10 times this amount or 100 times this amount, 190 million which are at risk of getting the disease. In our area, it's active in Myanmar, Nepal, India, all these areas, very active. These are the latest figures of our country, which is there. We have 2019, we have the WHO figures. 92,622 required surgical treatment, 95.2 million required antibiotics, and 57% of those who required antibiotics were covered by the antibiotics. So we have a large group, 43% still not covered. 1998, the WHO announced that they targeted global elimination of trachoma. So we had a national program, trachoma elimination program, which was there, and we also, which was merged with the national program for control of blindness. And we ran this program for some years, and then on 11th December 2017, India declared the elimination of trachoma. Currently, the prevalence, that means if it is less than 1%, then we consider that the disease is eliminated from the country. That means it is not elimination. Please remember the difference between elimination and eradication. Elimination is once the disease is no longer a public health problem. Generally, when you reach a figure of 1% or depends on each disease, we keep a particular figure which is there. So it is no longer a public health problem, while eradication means the disease is removed from the country. While in India, we have not reached the eradication stage, we are still in the elimination phase, a prevalence of 0.7%, which is also quite large. 0.7% is of our 1.3 billion population which we have. It's a huge, huge number, a very huge number. So we have, as in any disease, we'll consider the agent factors, the host factors, and environmental factors. The agent factor, chlamydia trachomatis. The serovarium which are there are A, B, or C in Asia and Africa, and D to K, which are there, are diseases of both the eyes as well as genitals. A, B, and C are the ones which are basically only for the eyes. The trachoma of the eyes is A, B, and C. D to K is eye and genitals. We also have infant the infection of in infants by the chlamydia can result in infant pneumonitis or can also result in inclusion conjunctivitis. The other pathogenic organisms which contribute or add on to the infection, as you're aware, the most common cause of conjunctivitis is the Morax Axenfeld Diplococcus, which is the most innocuous but is very common as far as conjunctivitis is concerned, the Morax Axenfeld Diplococcus. And the Haemophilus aegyptus, which is there, or also called the Cockbeak's bacillus, is also one of the most widespread for infection for causing conjunctivitis. And these two add on to the chlamydia trachomatis infection. They create a complex which is there and which results in more problems and can result in blindness. Gonococcus, if it comes along with chlamydia, is very dangerous and can result in blindness for the child and child or for that matter the adult, and we can have a lot of problems. The reservoir of infection is a person, especially children with active disease or chronically infected older children and adults. All these people are the ones who are the reservoir of infection. And as I mentioned earlier, because of the infection and superadded covalent other infections which are there, you get lots of discharges from the eye. These discharges from the eye are the source of infection, and these through the fingers, through other fomites which are there, or for example, towels or kajal, etc., that we mentioned. This is transmitted from person to person. So fomites are also a major source. Fingers are the most important source of the mode of infection is most commonly through the fingers. Communicability, it has low infectivity, but since the infection was so very prevalent, we had large number of cases. It is not once the cicatrization takes place, there are no discharges which are occurring in the eye, then there is no infection which can occur. Basically, what we are looking at, infection takes place whenever there are discharges from the eye. A disease which has traveled further and result in cicatrization may not be infective in nature. So what happens is when a patient comes and in the early stages when he has discharge from the eyes and is not treated, that's the time when the person is actually infected. But when the patient comes later and we know that it has reached a stage of the disease, blindness and cicatrization has taken place, he's really not infective at that time. So in endemic areas, children are the main source of infection as well as main people who get infected. From a few months old children to 2 to 5 years, these are the ones which most get infected. These are the children who are vulnerable, and we must ensure that we look after these children. It occurs in all age groups, females more than males. In the older age group, people used to think possibly because the use of kajal, surma, and various other things in the eyes by females, and the sharing of this was possibly the reason why females used to suffer more than males. Also, the females are more in contact with the infected children, and they have other aggravating factors like when they're cooking, they have a lot of smoke, and chances of more infection which takes place. The predisposing factors are direct sunlight, dust, smoke, and irritants. Kajal or surma are supposed to be soothing to the eyes, whether they are soothing or whether they are irritants. There's a lot of controversy in this. I will not like to go into details of this in this particular class, but yes, uh, kajal or surma, which people used to use even charcoal as kajal earlier. All these things are possibly bad for the eyes, and they are the predisposing factors for the disease. The most common season where it is most common is when the temperatures are high and the rainfall favors fly populations of flies being present, unhygienic conditions, secretions from the eyes. All these will add up to the transmission of the disease. The quality of life, again, those people who are not educated. Education does not mean only primary education or various education. Education also involves a degree of education as to the standard of living. So, but whenever there is poverty or ignorance, poor personal hygiene, which illiteracy, all these things add on, and the people are staying in more unhygienic conditions. They stay in the slums, and they've not got sufficient water to keep washing their hands and keep washing their eyes and face. These are the people who are likely to suffer more from the disease. The quality of life definitely matters, because if you've got the requisite facilities for washing your hands regularly, for washing your face regularly, keeping yourself hygienically clean, then the chances of transmission go down. Also, wherever the garbage, etc., is disposed of properly, you will not find flies, and that's the reason why quality of life is most important. Customs applying kajal or surma to the eyes poses a risk, especially when you are sharing these particular things. How do you diagnose? Epidemiological studies which are there show that you have got the upper tarsal is one of the one regions where you would like to look for upper tarsal conjunctiva, which is an index for uh, classifying the disease. So the criteria is that if you the diagnosis can occur if you've got at least two of these four conditions which are there. One is follicles on the upper tarsal conjunctiva. Second is the limbal follicles or the sequelae. I will show you these in more in detail in the next few slides. Or you have Herbert spits which are there. And third is a typical conjunctival scarring or trichiasis or an entropion or a vascular pannus. Now, the pannus means an increased blood circulation, which is there, which can occur. It occurs on the superior limbus, superior portion of the conjunctiva, which is there. So I'm sure you've seen all these things in ophthalmology, but in case you've not seen, I'll just show you some of it. Where was that? Yeah, it is here. We'll be talking about that. Okay. Control of the control programs in the communities we of blinding trachoma, we look for corneal blindness. We could look for trachomatis trichiasis or entropion, moderate severe trachomatis inflammation, and these all these things we'll look for when we are there in the community. And the control of blindness, um, what we're looking at, we target that we should have any countries which are having blinded rates greater than 0.5%. These are the countries which we need to target for control programs. Now, as we mentioned earlier, now let us look at the WHO classification for trachoma. WHO classifies trachoma into five different grades. TF. TF means trachomatis follicular reaction, that is more than 5 follicles larger than 0.5 millimeters on the upper tarsus. What you have to do is you have to invert the eyelid. Once you invert the eyelid through, because that's firm, the upper eyelid can be inverted. You invert the eyelid and look for follicles. So 5 follicles which are larger than 0.5 millimeters on the upper tarsus, then you call it trachomatis follicular reaction. And uh, the second one is trachomatis infiltration reaction, that is associated with thickening due to infiltration and a hypertrophy which takes place, which obscures 50% of the large, deep tarsal veins. Now, once you've inverted and you've seen in ophthalmology, you will come to know that normally you will see the large, deep tarsal vessels in the upper tarsus, which is there. But when infiltration takes place and hypertrophy of this takes place, it obscures these large deep tarsal vessels, and that is the time that you classify it as a TI or tarsus infiltration. The third or tarsus or trachoma infiltration. Trachoma scarring, that is the next stage, which is conjunctival scarring. There is a feathered band seen on the upper conjunctiva. And the next is trichiasis or entropion. I'll show you a few more slides on this. And the last is corneal opacification, where you have a visual acuity of less than 20 by 60. So what you have to do is the upper eyelid has to be turned over to examine the conjunctiva over the stiffer portion of the upper eyelid. And the normal conjunctiva appears nice and pink, smooth and transparent. And large, deep lying blood vessels normally run vertically over the whole area. So you can see these things which are there. When trachomatis infiltration or trachomatis, first we'll talk about trachomatis follicles which are there. 5 or more follicles are seen in this area, or when you talk about infiltration, or you have the thickening of this tarsus taking place. Also, shallow pits at the margins of the limbus can be seen in the bulbar conjunctiva caused by the rupture of the lymphoid follicles, leaves some scars or depressions. And these depressions are called Herbert's pits, Herbert's pits. These are considered together with lymphoid follicles or vascular pannus. Pannus we'll talk about later as one of the most characteristic or diagnostic signs of trachoma. So when the tarsus get further thickened, the tarsal conjunctiva appears red, rough, and thickened, obscured more than half of the normal. You see, when I talked initially, I showed you the slide. You could see the tarsal vessels. Well, here in this particular tarsus, you cannot see the tarsal vessels. There are numerous follicles and partially covered by the thickened conjunctiva. Now, when the scarring takes place, the uh, trachoma scarring or scarring and fibrosis, which takes place of the tarsal conjunctiva, which is due to severe or chronic trachoma. And this is sometimes called psychiatrical um, trachoma. The scars are glistening and fibrous in appearance and easily visible as white lines, bands on even sheets. This is very clearly visible, and especially when you see through a slit lamp, you will be able to see this very well. Scarring and particularly diffuse fibrosis may occur. The deep conjunctival blood vessels scarring is important because it gives rise to blinding as a sequelae of trachoma. So you must look for the scarring. Again, when you look at scarring, this is one of the examples of more sheet-like. This was first stage. The second stage is when there is sheet-like fibrosis which takes place. Conjunctival blood vessels are totally obscured. You cannot possibly see any blood vessels. Severe scarring which is taking place in this particular case, and more commonly in women. Then you have trichiasis, that is basically is defined as occurring when at least one eyelash rubs on the eyeball as a result of entropy on inward, and the eye because of the scarring, the eyelashes start moving inwards. The interned eyelashes are irritating, leading to attempts to remove them. Evidence of recent attempts to remove interned eyelashes in a trachoma endemic community should be graded as TT, trichiasis. And when further next stage is the corneal opacity, the eyelashes keep rubbing the eye, and once the eyelashes keep rubbing the eye, there is a corneal ulceration which takes place. The corneal ulceration then heals with opacification, and there is loss of vision. The tragedy is that this loss could have been prevented at the right time if you had just ensured that the eyelashes did not touch the eye. So this is a simple procedure which can be done even in the villages. So what do we do as far as treatment is concerned? The objectives basically are to reduce severity, lower the incidence in long run, decrease the prevalence of trachoma. The antibiotic of choice is tetracycline. Ophthalmic ointment, oily suspension of tetracycline. You can use erythromycin, rifampicin. Actually, today when we come to the next slide, we'll see erythromycin being used. The mass treatment is basically if you want to do the whole house or you want to do the whole community. Selective treatment, population at risk is screened and treatment given to persons with active infections. So nowadays we are more relying on azithromycin, which is given as 20 milligrams per kg body weight, a single dose, um, and it cures about 78% of the infection. So you use a local tetracycline and orally give azithromycin. Alternatives are you give doxycycline, or you can give 100 milligrams 2 times a day, or tetracycline can be given in hyperendemic areas. Tetracycline or erythromycin ophthalmic ointments should be applied twice a day for 5 days, each month for 6 months. And this results in dramatic reduction in endemic trachoma. We have been used in our country, and we have given vast numbers of tetracycline, which has been given to the population, resulting decrease of, and of course, a single dose of azithromycin. Reinfection due to re-exposure is common in endemic areas, and basically what one has to teach them, health educate them, is to personal hygiene and environmental measures. Ensure that garbage is disposed of well. Eyelid deformities, that's the biggest. Entropion should be looked after, otherwise we are going to land up, as I said, with blinding. On healing, the conjunctiva is smooth and greyish white. The extent of residual corneal opacity and vision will vary. It depends on when if you've got an opacity, the opacity cannot be reversed. The reversal of opacity will not take place. You can possibly look at that the further opacity will not take place. Once controlled, the whole family should be kept under surveillance, and health education to improve the living conditions and quality of life is very important. Then we have the strategy which was started by the WHO, SAFE strategy, or for we call it GET 2020. It's SAFE being S for surgery, surgery to correct advanced stages of the disease. A for antibiotics. These were distributed by Pfizer earlier, but now being distributed by lots of various other organizations. Um, so they used to give antibiotics, and antibiotics was orally given. You give azithromycin, single dose. Also, you give tetracycline ointment. Face washing to reduce disease transmission, and environmental changes to increase access to clean water and improve sanitation. The trachoma control program in India was launched in 1963, and then it was, as I mentioned, it was merged with the National Program for Control of Blindness. And Health for All by 2000 had set a target of reducing prevalence of blindness to 0.3%. We are hoping to reach that particular stage. That's all that we have for trachoma. We are trying to cover 2, 3 things as rapidly so that you don't get bored. We will be covering next, I think we'll be covering tetanus next Monday. Tetanus, then we'll be going to leprosy. Please read up so that we can cover these things rapidly. You are entering a stage when you should have been ready for your exams. Your exams internal exams, final exams would have been held in the month of November. I don't know whether you all are ready as yet. We have seen your internal assessment, and you all have done quite poorly. I thought you would, since with the lockdown, you would have studied well, but I'm not very happy with what you all have done in your internal assessment. We'll have another internal assessment. There is a rumor that you will possibly be coming back from 15th of October. If not 15th October, at least 1st November, we expect most of you back, and we expect to have one more internal assessment in the month of November. So please get ready for internal assessment in the month of November, which will cover the complete syllabus. So we'll have that, and most probably your exams would occur at the right time, that is in the month of January, as is normally occurs. So we should be having it in the correct time, because things seem to be opening out and we should be having your exams in time. All the best, and hope to See you next Monday.